you for a kind introduction and this opportunity to interact with a lot of my colleagues on some clinical topics. Today, actually, I chosen a topic which is quite common for people working in ICU, that is hypoxemia. And we usually see many patients who require oxygen in the hospital and in ICU. And I just wanted to discuss some of the approaches to deal with the hypoxemia or hypoxia. So usually we start oxygen or a high flow oxygen or a NIV or ventilation to a hypoxemic patient. So this is a very routine kind of action to an hypoxic patient. But understanding mechanism of hypoxemia is critical for the evaluation of the patient with hypoxemia, because the main contributing mechanism of hypoxemia will help us to narrow down the investigations. So we'll do a more appropriate investigation and we'll target the appropriate therapy. So understanding mechanism behind hypoxemia is very important. So a couple of cases I just wanted to highlight. These are the few patients who got admitted in our ICU in last 3-4 months. He is a 65-year-old male of known chronic obstructive pulmonary disease, having cough and fever of 2-3 days. Came to hospital with breathlessness of 1 to 2 days. On admission, his heart rate is 90 per minute, blood pressure was normal, and he was having hypoxemia. His oxygen saturation was 84 on room air. His tachypneic RR of 35 per minute. So as I told you, everybody will start oxygen probably admitting in ICU. So this is our routine kind of case where we'll start oxygen, we'll start probably the multipara monitor, we'll get an X-ray chest done, ECG done, and some blood gas done. So this is what we did in this patient. And this is the ABG. We did X-ray. X-ray looks normal. A blood gas. I'll discuss the blood gas afterwards, but blood gas shows a mixed kind of picture, that's hypoxemia as well as respiratory acidosis. Looks like a case of acute exacerbation of pulmonary disease, chronic obstructive pulmonary disease. This is another case. This is a 56-year-old male. He is obese. He is lift by occupation. He has got sudden onset breathlessness, palpitation. Vitals shows tachycardia. Blood pressure was on lower side, 90/60. He was also tachypneic and saturation was 88 on room air. And his blood gas also shows PO2 of around 60 on room air and saturation of 88. So obviously, if obese person who has a occupation of sitting in the lift or standing in the lift with a picture of RVV and tachycardia, looks like a pulmonary embolism. And this patient also gets an hypoxemia. So, and we started oxygen to this patient, almost 15 liters by oxygen reservoir mass, but his saturation hardly improved from 88 to 90%, and not much improvement, and eventually required vasopressors to maintain the blood pressure. Then he was diagnosed as a case of pulmonary embolism and required thrombolysis and may require ventilation in future if it doesn't settle down. And this is the third case. This is a recent admission of 45-year-old female who is diabetic, hypertension and having hypothyroidism, having fever and cough of 3-4 days and breathlessness since last 2 days. She came to the hospital with a tachycardia, blood pressure is 130/70, respiratory rate is 28 per minute. Oxygen saturation was 90 on room air, which improved to some extent on 2 to 4 liters of oxygen per minute. And looks like viral pneumonia or community-acquired pneumonia on the history and probably on X-ray. Again, if we do an ABG, we have an hypoxemia obvious on the blood gas. So all 3 ABGs or 3 patients had got hypoxemia, but remember the mechanism of hypoxemia in each case is slightly different. So let us understand how hypoxemia occurs. As you all know, the pulmonary function or function of the lung is to get oxygen in and remove the oxygen or carbon dioxide out from the body. So oxygen in is very important part, and it depends on the partial pressure of oxygen in the alveolus, that is PaO2, that is capital A, then diffusion capacity of alveolar membrane, then ventilation, perfusion, and the perfusion and ventilation matching. So the oxygenation depend on this important factor, or alveolar oxygen, diffusion capacity, and ventilation-perfusion matching. So we talk about the alveolar pressure, which actually determine the oxygenation. The alveolar pressure is nothing but the sum of the partial pressure of different gases in the alveolus. So there are oxygen, carbon dioxide, nitrogen, and water vapors in the alveolus, and the partial pressure of each actually gives rise to alveolar pressure. And the alveolar pressure increases, the partial pressure of each gas increases in the alveolus. And if partial pressure of one gas increases, like if partial pressure of carbon dioxide increases, it causes decrease in the partial pressure of oxygen and will lead to hypoxemia. So, if partial pressure of carbon dioxide is increased, the partial pressure of alveolar oxygen actually decreases, and that will lead to hypoxemia. And you know, this is a model where this is alveolus, this is a deoxygenated blood from the capillaries, and it gets oxygenated, and blood leaving this alveolus is fully oxygenated if it is a normal alveolus or normal lung. So partial pressure of alveolar oxygen, which is a major determinant of oxygenation, is defined on fraction of inspired oxygen, then alveolar pressure. Again, it depends on the partial pressure of carbon dioxide in the alveolus, as I told you just now, and the ventilation. Then ventilation-perfusion matching, perfusion and diffusion capacity of the lung. The ventilation-perfusion matching is the most important pathology come across the ICU patients. In normal lung, all alveoli which are ventilated are well perfused. If you see, all alveoli are well ventilated and they are all perfused. So blood leaving this alveoli are fully oxygenated. So in normal circumstances, ventilation and perfusion ratio is 1. So this is kind of normal alveolus, where the venous oxygen saturation is around 75%, and partial pressure of alveolar oxygen is 100, and partial pressure of carbon dioxide 37 in the alveolus. So blood leaving this alveolus is actually getting oxygenated when partial pressure of oxygen is around 100. It's a normal kind of thing, and carbon dioxide is removed and oxygen is in from the alveolus. What happens in hypoventilation? In hypoventilation, this is a normal alveolus where partial pressure of oxygen in alveolus is 100 and partial pressure of carbon dioxide is 38. But when carbon dioxide increases to say around 77, in this case, the partial pressure of oxygen drops down, and the blood leaving this alveolus is not fully saturated, and the patient get hypoxemia. So this is hypoventilation causing hypoxemia, and this we need to understand in patients with hypoventilation. And in this kind of hypoxemia, just giving oxygen will increase the partial pressure of oxygen, and oxygen saturation will improve. So hypoventilation occurs because of multiple reasons, right from central nervous system like brainstem, spinal cord, nerve roots, airway diseases, neuromuscular diseases, diseases of the lung, pleura, chest wall, neuromuscular and respiratory muscles. So hypoventilation, which will lead to increased partial pressure of carbon dioxide in alveolus and subsequent decrease in the alveolar pressure of oxygenation, and will cause hypoxemia. The another most common mechanism of hypoxemia in ICU patient is shunt. The shunt, where the alveoli are not ventilated, but the perfusion is normal. So this blood leaving this non-ventilated alveoli are not getting oxygenation, and patient gets hypoxemia. The shunt is most common cause of hypoxemia in critical ill patient. So this is a diseased alveoli, and the blood leaving this alveoli is not getting oxygenated, and at the same time normal alveoli, which actually gives oxygen saturation is blood leaving this alveoli is fully oxygenated. And I think some the blood leaving, the effectively patient will have hypoxemia to some extent. But what happens in such cases of hypoxemia? There is a compensatory mechanism causes vasoconstriction to the disease alveoli, and blood supply to this alveoli is decreased, and blood supply to normal alveoli is increased. Because of this, shunt fraction is slightly reduced, and oxygen saturation goes slightly up to some extent, from, like in this patient, from 87 to 90%. But giving oxygen in this kind of shunt mechanism will not improve oxygen saturation to a greater extent. So intrapulmonary shunting occurs because of the most of the causes of the lung disease, like pneumonia, pulmonary edema, atelectasis or collapse, or pulmonary hemorrhage or contagion. And there are some intracardiac shunts, that is right to left shunt, because of different etiologies like Fallot's etiology, Ising-Minger complex, or pulmonary hypertension with patent foramen oval. The exact opposite of shunting is a dead space ventilation, where alveoli are ventilated but not perfused. And this is a extreme of the case of shunt. In ICU patients, as I told you, ventilation perfusion are never matched to the demand, and the ventilation perfusion ratio is actually broadened. And remember, you don't get a very clear-cut patient most of the time in ICU. You have a mixed patient, so sometimes there are two or different mechanisms of hypoxemia in one single patient. So that you have to remember in treating the patients of hypoxemia. So this is a broad algorithm to approach to the patient with hypoxemia. So patient is hypoxemic. The next step one should do is calculate the alveolar arterial oxygen gradient. See, we always do a blood gas and we see PaO2, we see saturation, we see pH and bicarb, but we never give good attention to AA gradient. We get AA gradient from the blood gas and FiO2. I'm going to talk to you how to calculate AA gradient in the next few slides. But if you calculate AA gradient and AA gradient is normal for that patient's age, then probably the mechanism of hypoxemia is hypoventilation. And this hypoventilation actually response to the oxygen is very good. If AA gradient is increased or widened, then there are three mechanisms of hypoxemia. One is ventilation-perfusion mismatch, then diffusion abnormalities like pulmonary fibrosis, or a shunt mechanism. And in this case, if there is a shunt, the response to oxygenation is very poor, and VQ mismatch and diffusion abnormality may respond to oxygen. So this is the way you can actually categorize the mechanism, different mechanism of hypoxemia by calculating AA gradient and then looking for the hypoventilation or no hypoventilation. So what is AA gradient? This is the alveolar arterial oxygen gradient, the difference between the amount of oxygen in the alveoli and the amount of oxygen dissolved in the plasma, that is arterial oxygen, measured by blood gas. So AA gradient is calculated by PaO2, that is alveolar oxygen minus arterial oxygenation. For example, if PaO2 is 100 and PaO2 is 92, the AA gradient is 8, that is normal. So 25 or less than 25 is a normal AA gradient to the most of the adult patients in the ICU. So PaO2 is calculated by this formula. This formula is PaO2 is equal to barometric pressure minus water vapor pressure multiplied by FiO2 minus PaCO2 by a respiratory quotient. So you get FiO2. If patient is on ventilator, you can calculate the FiO2, or if patient is on room air, you can consider it as a 0.21. PaCO2 you get on ABG, and according to this, so arterial oxygen saturation, this PaO2 is dependent on FiO2 and PaCO2, and you can calculate PaO2 and then calculate AA gradient. So the AA gradient, if you consider normal room air AA gradient for normal lungs and consider PaCO2 as 40, then PaO2 is 100 and 100 minus 92 is 8. So this can how we can calculate AA gradient. So is it really useful to calculate AA gradient? Yes, clinically significant hypoxemia is associated with widened AA2 gradient. Is commonly due to VQ mismatch, can be seen in atelectasis, pneumonia, then aspiration pneumonia, pulmonary edema, or ARDS. So most common causes of ICU admission is because of VQ mismatch. Then it can occur because of right to left shunt, and diffusion impairment occurs when limitation exists to the movement of oxygen from the alveoli to the pulmonary vasculature, like severe emphysema or lung fibrosis. So widened AA gradient actually denotes either there is a problem with VQ mismatch, is there is shunt, or a diffusion abnormality. If there is normal AA gradient, the clinical hypoxemia with normal AA gradient occurs in a setting of low inspired partial pressure of oxygen. This occurs when actually on the basis of alveolar gas equation, this results from multiple factors like low FiO2 or low barometric pressure. That occurs at high altitude, the barometric pressure decreases and the partial pressure of oxygen is low at high altitude, and patient will get hypoxemia because of the normal AA gradient. The another cause of normal AA gradient and hypoxemia is significant hypercarbia. Elevation of arterial PCO2 level can decrease in the alveolar gas levels. Pure hypercarbia is often result of hypoventilation syndrome that I told you, from central nervous system to the lungs. There are different causes of hypoventilation. This can be related to multiple factors like CNS depression, obesity, hypoventilation syndrome, impaired neural conductions like GBS, cervical spine injury, phrenic nerve paralysis, muscular weakness because of myasthenia gravis, neuromuscular dystrophy, or argonophosphosis poisonous snake bite, poor chest wall elasticity such as failed chest or kyphoscoliosis. In this case, just giving oxygen will definitely improve the oxygen saturation. So to conclude, the most common causes of hypoxemia in ICU are VQ mismatch. The physiological dead space and shunt are extreme forms of the VQ mismatch. So one side there is a dead space ventilation like in pulmonary embolism, and other side is a shunt which occurs in multiple lung diseases like pneumonia, ARDS, collapse, and consolidation. Virtually any lung disease can be included in this category. Common in ICU, pneumonia, inflammatory lung disease like ARDS, obstructive lung disease, hydrostatic pulmonary edema, and pulmonary embolism. Then we always calculate PaO2 FiO2 ratio, particularly in patients of ARDS who are on ventilator. And you know the Berlin definition of ARDS actually defines severity of ARDS depending on the PaO2 FiO2 ratio. If PaO2 FiO2 ratio is less than 300, it is a mild kind of ARDS. If it is 200 to 100, it is a moderate, and less than 100 is a severe ARDS. So PaO2 FiO2 ratio is an indirect estimate of shunt fraction. If PaO2 FiO2 is less than 200, shunt fraction is more than 20%. And if PF ratio is more than 200, the shunt fraction is less than 20%. The major limitation of this PF ratio calculation is inability to estimate FiO2 accurately when patient is on supplemental oxygen delivery through nasal prongs or an open face mask. So you can calculate FiO2 exactly, and you can calculate the PaO2 FiO2 ratio. Then something about the mixed venous oxygen saturation. When we learned about the early goal-directed therapy few years back, one of the target in early resuscitation of shock patient is to keep mixed venous oxygen saturation more than 75. The mixed venous oxygen saturation, that is O2, in the arterial blood represent the sum of the oxygen of oxygen in the mixed venous or pulmonary artery blood and the oxygen added from the alveolar gas. So arterial oxygenation actually depends on these two factors. One is the mixed venous oxygen saturation and the oxygen added from the alveolar gas. When gas exchange is normal, the PO2 in the alveolar gas is the major determinant of the arterial PO2. However, when gas exchange is impaired and the contribution of alveolar PO2 is declined, the contribution of mixed venous oxygenation actually rises. The greater the impairment of gas exchange, let us take example of ARDS or a pneumonia, where partial pressure of oxygen is low or patient is in hypoxemia, then probably the mixed venous oxygen saturation will take some of the load to maintain the oxygenation of the arterial oxygenation. The greater the impairment in the gas exchange, the greater the contribution of mixed venous PO2 to the arterial POCO2. And if there is no gas exchange in the lung, the mixed venous PO2 would be the sole determinant of the arterial oxygenation. So mixed venous oxygen saturation actually decreases when there is a decreased oxygen delivery and increased oxygen extraction from the tissues, probably patient in the shock. So to conclude, in a patient with hypoxic respiratory failure, you calculate AA gradient. If AA gradient is increased and it improves with the oxygenation, if yes, then you are actually looking at VQ mismatch. If AA gradient is increased and there is no improvement with the oxygenation, you are dealing with a shunt as a mechanism of hypoxemia. If AA gradient is normal and you get a high PaCO2, so there is a hypoventilation syndrome, yes, then hypoventilation is the cause, and oxygen actually improves the oxygen saturation in this patient. Normal AA gradient with normal PaCO2, then it is a low inspired oxygen, that is in high altitude kind of patients, you get the hypoxemia. So this actually explains the whole story of mechanism behind the hypoxemia. So let us go back to our 3 cases we started discussing at the time of starting my lecture. So this was the first case of a COPD with some acute exacerbation with a hypoxemia. The saturation 84 on room air, and we did the blood gas. If you see a blood gas carefully, sorry for this slide, this patient has got PCO2 of 75 with respiratory acidosis and hypoxemia. So this patient has got hypoxia with respiratory acidosis with good compensation. The AA gradient in this patient was 8. So the cause of hypoxemia is hypoventilation secondary to COPD. And oxygen actually improves the saturation in this patient. This is another case, obese lady, obese liftman having a sudden onset breathlessness, palpitation, hypoxia, and diagnosed of pulmonary embolism. If you see, the pH is normal, PCO2 is normal, but he has got severe hypoxemia on room air. So we calculate AA gradient was 40. So it was high, and saturation, in spite of giving 50 liters, hardly improved. So there is no improvement with the oxygen saturation by mass. So in this case, the mechanism of hypoxemia is dead space ventilation, that is VQ mismatch. And this is third case, this case of diabetes, hypertension, hypothyroidism with fever, cough, and breathlessness. And the saturation is 90, and PO2 is something like 60 on room air, and minimal improvement with the oxygen. So this patient ABG shows hypoxemia, but normal PCO2 and high AA gradient. So mechanism in this patient is shunt as a cause of hypoxemia, and this patient has got bilateral shadows on the X-rays, looking like viral pneumonia with ARDS. So patient has got shunt as a cause of hypoxemia and will require oxygen high flow NIV or intubation as a treatment. So to conclude, the hypoxia is very common in ICU patient, and patient requires oxygen or some other supportive ventilatory support in most of the patient, but understanding mechanism is very important. Sometimes hypoventilation can cause hypoxemia, and VQ mismatch, that is dead space ventilation or shunt, is the most common cause of hypoxemia in ICU patients. And depending on the etiology of hypoxemia, the treatment depends on the treatment of the cause. Like if a patient is having embolism, you'll have to thrombolize the patient. If patient is having pneumonia, you'll have to give antibiotics or antiviral drugs depending on the etiology of his pneumonia. And if patient is having COPD exacerbation, you may have to give bronchodilators, steroids, and probably this patient of hypoventilation requires non-invasive ventilation and will take care of his retain PCO2 and hypoxia will improve. So that's what about the today's topic, the approach or to deal with hypoxemia. Thank you. If there are any questions, you can either ask or you can write in the chat box.
Do anyone has any queries, any questions? Okay, doctor, I don't think that anyone has any query or any questions because we so if something come across, so definitely we'll get back to you. Our team will be in contact with you.
Yeah, yes.
Yeah, sure.
Thank you.
And, behalf of Poland Healthcare, we would like to say sincerely thank you so much for connecting and giving a very knowledgeable presentation. And hope this will be we will keep continue in next sessions also.
Yeah, I think next month we'll have a approach towards respiratory ascites, that is PST2 retention. Now we consider hypoxia, how to deal with hypoxemia.
Right.
Next time we'll discuss about the approach towards respiratory ascites.
Definitely, sir. We'll be more happy to associate with you for this knowledge gain. Okay, sir, thank you so much. Thank you everyone for connecting.
Thank you everybody for joining this CME. Thank you.